Hello, everyone. Getting ready to begin. Hello, my name is Marta Alonso, and I'm part of the Clinical Marketing Communications team here at City of Hope. We welcome you to our Ask the Experts series. Our topic this evening is lung cancer, and we're very fortunate to have two of our very own City of Hope professionals, Dr. Dan Raz and Dr. Jae Kim. Just a few friendly reminders before we begin. City of Hope is a non-smoking campus. Please remember to put your cell phones and pagers on vibrate out of courtesy to those around you. The restrooms are located outside the door to your left. We also ask that you please take a moment at the end of the presentation to complete your evaluation forms. We do pore over your comments to make sure that we are offering you the types of programs and educational series that you're interested in, so your feedback is extremely important to us. We will have a question and answer session at the end of the presentation, so we encourage you to please write your comments down or questions on the index cards, and we will come around to collect them as we near the end of the session. The event is being streamed live and we will be available to view on the City of Hope website and our City of Hope YouTube channel. For those of you joining us online, we encourage you to join in the conversation and send us your questions. So to start with, Dr. Raz. All right. Well, before we begin, as part of our program this evening, we wanted to share an inspirational video of a lung cancer survivor who was treated here at City of Hope. This is the story of Sue.
I had been cancer-free for 20 years. I didn't expect any kind of a phone call at all, so I was totally floored, totally. And I just went in for my usual checkup, and that's when I was diagnosed with lung cancer. I've never smoked, and I thought it was only smokers, so we had to get a fast education. And within a week or so, our son from London was coming in with his fiancée, and it was a very difficult thing to tell, and I actually broke down a bit. And as a family, we decided where we wanted to go to get the best care possible. We looked at some of the major institutions in Southern California before we selected City of Hope. Just driving into the institution, into the whole campus of City of Hope, it was a very warm, welcoming feeling. And there's big trees and gardens that you walk by. And then the volunteers, they're just smiling. We had the appointment with Dr. Reckamp, and the minute I met her, I felt very comfortable. She talked straight to me. She was sitting there to answer all my questions and was not in a hurry to leave the room at all. And she recommended that I do chemo while we waited for the results of the lung biopsy, and it did shrink my tumors. If I had any friends diagnosed with cancer, I would definitely recommend that they consider City of Hope, and I might just meet them there and help walk them through the process. I would never look back or ever consider another institution for my cancer care. Yeah, I am very pleased to be at City of Hope.
So our first speaker this evening is Dr. Dan Raz. Dr. Raz joined City of Hope's Department of Surgery's Division of Thoracic Surgery in January 2011 as assistant professor and is current co-chair of the Lung Cancer and Thoracic Oncology Program and surgical director. Dr. Raz's experience lies in esophageal and lung cancer surgery. He earned his Bachelor's of Science degree in biology from Massachusetts Institute of Technology and his medical degree from the University of Pennsylvania. He completed his residency in general surgery at the University of California, San Francisco. While at the University of California, San Francisco, Dr. Raz also earned his master's degree with advanced studies in clinical research and was a research fellow in the Thoracic Oncology Program. Most recently, Dr. Raz was a fellow in cardiothoracic surgery at Massachusetts General Hospital in Boston and spent time at both Memorial Sloan Kettering Cancer Center in New York and the Mayo Clinic in Rochester, Minnesota. Please extend a warm welcome to Dr. Dan Raz.
Thank you all for coming tonight. I'm going to give you a little background on lung cancer, and my part of the talk, I'll talk a lot about lung cancer screening, which is a really important development in lung cancer, and talk just the nuts and bolts of lung cancer staging, and give you a little flavor of molecular testing and something called chemo prevention for lung cancer. And then Dr. Kim will talk a little bit more about treatment options for early stage lung cancer. First of all, I want to make sure you all are aware that November is Lung Cancer Awareness Month. And does anyone know the ribbon color for lung cancer? Aside from Anna Cathy. White, so yes, it is white. And I don't know how many of you knew that. I'm sure you all know last month was Breast Cancer Awareness Month, and it's hard not to know that. Breast cancer advocacy groups have done a fantastic job that we can all learn from and appreciate from. But the really tragic thing is that lung cancer kills more people than colon cancer, breast cancer, prostate cancer, and pancreatic cancer combined. And even among women, lung cancer far exceeds the number of cancer deaths compared to breast cancer. And so this month, we're really happy to open our doors to all of you and have all of your questions answered, and to shed light on some new advances that have been made in treating this cancer. One of the reasons lung cancer doesn't get as much attention as it probably deserves is its association with smoking, and there's a stigma associated for that, for better or for worse, even though nobody deserves to get lung cancer. About 85% of people who develop lung cancer are either current or former smokers, and about 15% of people who develop lung cancer have never smoked in their life. And amongst women, that number is much more common. So about a quarter of all women have never smoked any cigarettes, and amongst Asian women, that number is about 75%. I think it's also important to know the definition of smoker when we talk amongst doctors or researchers. That means if you've ever smoked 100 cigarettes over your lifetime, you are considered to be a smoker. So even people who've had a very, very, very light smoking history might be included in that group of current or former smokers. And then, of course, people always raise a question of secondhand smoke exposure, which is clearly an important risk factor, but very difficult to determine exactly how much of that is attributable to a particular case of lung cancer, because it is difficult to determine how much secondhand exposure a lot of people get. And there are other important risk factors to lung cancer development other than tobacco smoke. One of them is radon, which many people consider to be the second most important cause of lung cancer after tobacco exposure. And it is additive to tobacco smoke. Occupational exposures, meaning certain things, certain occupations that have certain kind of chemical exposures, are thought to contribute almost 8% of all lung cancer cases. And then especially in Asian countries, in China especially, exposure to coal inside for cooking and hot oil for cooking is thought to be a contributor to lung cancer causes. And nobody really knows the effect of environmental pollutants from, diesel fumes are known to be important, but just from car exhaust and that sort of thing in terms of how much of an effect that has on lung cancer, because it's all around us and it's just a really hard thing to study. And of course, a few years ago, Dana Reeve put a face on lung cancer in never smoking women and really shine a light onto the fact that lung cancer is first and foremost a disease that happens to people, but also a disease that happens to people who haven't smoked. And one of the reasons, the main reason why lung cancer is so deadly is that it is detected at such a late state so much of the time. So stage 4 is the worst disease of all, when the cancer is spread outside of the chest to other parts of the body. And you can see that most of the time it's diagnosed in either stage 3 and 4 where treatment is unlikely to be curative. In stage 1, where it's most likely to be curative, it's only diagnosed right now about 20% of the time. And almost always that's found by accident. Someone happens to get a chest x-ray before a knee operation, or they get a CT scan for one reason or the other, and they're found to have a lung nodule. And the reason this is so important is that early diagnosis, especially in stage 1, is associated with a cure rate of about 60–70%. And the smaller the tumor is when it's found, the better the success rate of curing it. And you can see here with stage 4 disease, we generally don't consider that to be curative disease. And even with stage 3 disease, the vast majority of people are unfortunately not cured. And so just like we have with mammography for breast cancer and colonoscopy for colon cancer, lung cancer screening has been something that we've all been very excited about and promoting. Years ago, people started using chest x-rays to screen people for lung cancer. And by and large, that's been found not to be an effective way to reduce the death rate from lung cancer. But this group in New York, called the Early Lung Cancer Action Program, began screening people with CT scans, and they came up with some very sophisticated ways to follow very tiny nodules and determine who should have nodules removed in a way that made it very, very safe and very effective at catching lung cancers early. What they found was about 80% of lung cancers in people who were screened were detected at stage 1 instead of 20%. And of those stage 1 patients who were treated, 90% of them, not 60 or 70%, but 90% of those patients were cured with treatment because they were detected at such a small size. And in their work, they found that they were able to decrease lung cancer deaths by about 60%. What that means is if you were just to screen smokers alone, you would be able to save 82,000 lives in the United States a year, which is 224 lives a day. And just to give you a sense of what that means compared to things that we're used to, mammography has become something that we're all, is such an established part of our healthcare system. That reduces the rate of breast cancer death by about 15%, whereas we're talking about something that reduces lung cancer death by about 60%. Well, that study and that group had some problems. It was not what's called a randomized control trial, which means it did not have a direct comparison group. And so there was a lot of criticism about it. It didn't have strict entry criteria, meaning they didn't specify exactly what age you need to be, how much smoking history you had to have in order to enroll in that. And then, worst of all, the principal investigator of that study received some funding that came from a foundation that was given money from a tobacco industry. And so everything kind of got, majorly, I wouldn't say shut down, but a lot of the work got discredited, unfortunately. And while this was all going on, the National Cancer Institute actually funded a trial called the National Lung Screening Trial, which did just what all the shortcomings of the LCAP needed, which was they randomized groups of people to either get a CT scan or a chest x-ray, and they only had money to screen people for 3 years. So rather than screening people for 10 years or 15 years, they set up and designed this trial to screen people for 3 years only. So they got 3 CT scans and then followed them for a few years after that. And they had very strict criteria of the highest risk group patients to determine who should be allowed to enter to this study. And what they found was in just this 3-year period, there was a 20% reduction in deaths from lung cancer. And while that's not as big as 60%, you can imagine that if you extended that for longer than 3 years, you would see a much greater reduction in lung cancer deaths. They had to stop this trial early because they didn't feel that it was fair to continue this study given this information. And there are other potential benefits to lung cancer screening. So given the fact that these are screening in people who've smoked or used to smoke, there are other diseases that come with smoking, such as heart diseases, and you can actually see calcifications within the coronary arteries of the heart. You can see aortic aneurysms. You can see emphysema before it's apparent clinically. And very importantly also, it gives a point of action to encourage people who are still smoking to stop smoking. And so having lung cancer screening integrated with tobacco cessation like we do here at City of Hope has been shown to be very, very important. And so with anything that we do in medicine, there are risks. And so what are the risks of lung cancer screening? Well, some people actually died of procedures related to investigating what these nodules were. So of the 50,000 people in the study, 16 patients died within 60 days of the procedure that they had. It doesn't necessarily mean they died of the procedure, but some people died of the procedure, some people died within 60 days of that procedure. But still, this was a very, very low number, and the number of people who were saved by detecting their lung cancers early was felt to far outweigh the risk of any invasive procedures. Radiation exposure is always a question that comes up, and there have been papers that have estimated the number of lung cancers that can actually be induced by screening. And the thought is that if you were to screen someone with a low-dose CT scan for 15 to 20 years, not 3 years, but 15 to 20 years, you would probably cause between 1 to 2 cases of lung cancer for every 100 people you screen. So not insignificant, but at the same time, you'd probably save a lot of people from lung cancer death. And then, of course, there's anxiety related to going through a screening process, finding nodules that need to be investigated. And just to show you, we calculate doses of radiation for medical studies using this unit called a millisievert. And just to show you, in general, the average low-dose CT scan is about 1 millisievert. That's about what we use here. And background means just walking around, living life on Earth. You get about 3 millisieverts a year. A regular IV contrast CT is about 8 millisieverts. And a diagnostic mammogram is about 0.7 millisieverts, so not too much more than a diagnostic mammogram. And it turns out that lung cancer screening is cost effective, because at the end of the day, this all boils down to cost when it comes to the people who make the decisions about whether to pay for this or not, unfortunately. And a recent study showed that the cost per life of year saved was about $19,000, and when you compare that to mammography, it's about half of what it costs to save a life from mammography. And in terms of the perspective of an insurance company, it costs about a third what it costs for a company to provide for mammography. So the long and short of this is, why isn't everyone getting lung cancer screening? Well, slowly, but the way it actually has to happen is you have the clinical trial, then the next thing is that medical groups have to review the trial and give a A-OK on it or not. And then there's this thing called the U.S. Preventative Services Task Force, which is a big policy agency in Washington, D.C. that meets and reviews all the information, decides whether they want to adopt this as an approved screening recommendation. And that's extremely important because Medicare decides whether to pay based on that. Most insurers follow Medicare based on that. And most primary care physicians tend to follow that, although not all. And a lot of the quality measures that people get measured on, especially primary care physicians, depend on whether our people are following these recommendations. And while lung cancer screening has been adopted by or endorsed by a lot of medical societies, the American Cancer Society has been kind of lukewarm to it for reasons that are a little bit unclear. And the U.S. Preventative Task Force will not discuss this until 2014. A lot of this probably has to do with concerns regarding payment. People don't want to pay for something that will affect millions and millions of people, even though it saves lives and it's the right thing to do. So until that happens, and we're working on trying to make that happen sooner, Most places require that people pay out of pocket $300 to $400 for a CT scan every year. And that's a significant burden for a lot of people. In addition, there's concern that you got to do this in a center that has experience, knowing what to do when you find a lung nodule, having a team of people that will be able to manage the findings and to integrate that with tobacco cessation program. So here at City of Hope, we use the National Comprehensive Cancer Center guidelines in terms of our criteria for who gets screened. It's essentially people over 55 who smoke more than 30 years, or people more older than 50 who smoke more than 20 years but have an additional risk factor. And so if anyone is interested or knows someone who may qualify for that, we have more information that we can help you with. And currently, WellPoint and Anthem have said that they will pay for it, but it's a little bit on a case-to-case basis at this point. And just to briefly go into what happens when a suspicious nodule is identified, most of the time, a follow-up imaging study is recommended, meaning another CT scan or perhaps something called a PET scan, which I'll show you an example of. But when the nodule is big enough or is growing, we typically will recommend a biopsy for diagnosis. And the main ways we do this is either do a needle biopsy, so that's done by one of our radiologists, done with a CT scan with a needle through the side. It's a very safe procedure that's done as an outpatient. Another one that I'll show you a picture of is a biopsy that can be done with bronchoscopy using something called navigational bronchoscopy, which actually uses something like GPS to direct you to the nodule, and you can biopsy it that way. And then the last thing, this is a picture of that. This is a pretty neat technology that allows you to use the CT scan image and bronchoscopy, which is a video inside the airway, to guide you to that nodule, which in this picture is in the green, and allows the operator to then get to that nodule and biopsy it. And then the last thing, when those things are not possible, is to do a surgical biopsy or a wedge resection. And what that means is you basically just take a little piece of lung out that has the nodule within it. Sometimes we do that when we feel like the nodule needs to come out anyway, and that's something that you'd have to talk with your provider about. And then after that, the pathologist is a person who reviews the nodule and says if it's cancerous or not. And if it is cancerous, if it is lung cancer, there's two main kinds of lung cancer. Non-small cell lung cancer, which is a number of different types, but the two main kinds are adenocarcinoma and squamous cell. And the second most common kind, about 20% of the lung cancers, are small cell lung cancer. And then the next step becomes staging. So the first thing we always want to do is make sure that the cancer hasn't spread outside of the chest, so to make sure it's not stage 4 disease. And the two studies we typically order to do that are something called a PET CT scan. What that is it's a scan that uses a labeled sugar to identify tumors that are rapidly dividing. And they take up this labeled sugar and it turns it a bright color. You can see the brain takes up lots of sugar normally, as does the heart, and the kidneys excrete it. And so it's not a good test to look for spread to the brain. And that's why we also order a brain MRI in addition to the PET CT scan. So that's to make sure that there's no spread outside of the chest. And then the other important thing to determine the stage is lymph nodes. The lymph nodes around the lung in the center of the chest. And the first study we get is the PET CT scan. But if the lymph nodes are involved or they look like they're involved on the PET scan, that doesn't necessarily mean that they're involved. So if it lights up, that can be wrong anywhere between 10 to 50% of the time, depending on where you live in the country, because there can be certain kind of fungal infections that cause that and other causes. And even if they're not involved, about 10% of the time, they can still have cancer in them. And so on a case-to-case basis, if this happens, we oftentimes will sample the lymph nodes before doing anything else, either by something called mediastinoscopy or endobronchial ultrasound, which I think Dr. Kim is going to go over a little bit. And again, staging is important because it separates people into categories for treatment. So stage 1, we typically treat with surgery. Stage 2, typically surgery followed by chemotherapy. Also, sometimes we flip-flop these. 3A is typically treated with a combination of chemotherapy and radiation therapy with or without surgery. And then 3B is typically treated with chemotherapy and radiation therapy. Stage 4 is typically treated with chemotherapy alone, although in some cases we do use surgery, but it's on a case-to-case basis for these stages. Very briefly, one of the really great things is, wouldn't it be nice if rather than just relying on lymph nodes, if we could have a little bit more information using the genetic material of the cancer to determine what kind of treatment we should assign. So if we could biopsy the cancer and then determine whether to give certain kinds of chemotherapy, what's called targeted agents, to operate, to give radiation therapy, and that's really been the goal of a lot of different researchers, is to try to personalize therapy based on the genes within the cancer. And there are these things called driver mutations. And so what that is this has kind of become accepted now in lung cancer, that there are certain mutations that are thought to be the most important in a particular type of lung cancer, even though there are many, many mutations that occur within a particular lung cancer. And one of the reasons that we feel that this is the case is that take these two most common ones, KRAS and EGFR, they never happen together, and that's why the thought is that these each are important. And drugs have been developed to target these particular driving mutations with the idea that if you can specifically knock out that pathway, you can treat those tumors in a way that's just more intelligent than just delivering chemotherapy, which is basically a medication that kills cells that are dividing. And so in lung cancer, we have two targeted therapies. One is Tarceva or erlotinib that targets the EGFR mutation, and the other is crizotinib, which targets the EML-ALK translocation. Right now, these are both only used in advanced lung cancer, so mainly in stage 4 lung cancer or in patients who have a recurrence of a lung cancer. But in the patients who have these mutations, there is improved survival. Unfortunately, with erlotinib, even though it tends to work nicely in people who have a good response to it, people eventually develop a resistance to it. And although it's nice in that it's a pill, it also does have some side effects, especially rash and some GI toxicity. We are waiting for a trial that looked at the Tarceva in earlier stage lung cancer patients as an adjuvant, meaning after surgery treatment, but that's not available to us yet. I worked, and Dr. Kim actually was involved in this too, back in our days at UCSF, on a test to determine the outcome of lung cancer, meaning can you predict which of the stage 1 lung cancers go on to survive and which go on to become more aggressive, because perhaps you need to treat the ones that are have a worse prognosis with chemotherapy in addition to surgery, and maybe the ones that are less aggressive you can get away with maybe taking out less lung or treating with radiation therapy or doing something less aggressive. And so we took genetic material from early stage lung cancer, measured expression levels in about 70 genes that were previously found to be important in predicting lung cancer survival, and we found a set of genes that could predict the risk of death from early stage lung cancer. And eventually, this was a very large study with patients from UCSF, Kaiser Permanente, Northern California, and in China, validating this assay. and it broke people down into 3 different groups of survival. And this is actually now commercially available, and so it's one step towards this personalized medicine. The thing is, we don't really know how to use it yet, in the sense that there's no proof that if you treat these people with chemotherapy that they do better, and then if you treat these people with anything less that they do any better either. So that's kind of the next step to all of this, is to do a clinical trial to treat these people different and see if it makes any difference. And then the last thing I want to briefly touch on is something called chemo prevention. So just the way that people take an aspirin or cholesterol-lowering medication to prevent heart disease, wouldn't it be great if you could do the same thing to prevent lung cancer? Take a pill every day if you used to smoke or you currently smoke, to reduce your risk of lung cancer. And obviously the most important thing is to stop smoking, but people have looked at vitamin E, B12, and beta-carotene for just this thing in a variety of cancers with no impact at all. People have looked back at aspirin, and there may be a very small benefit for preventing lung cancer. And now there's been a lot of interest in Celebrex, in possibly having some additional effect in preventing lung cancer. And there have been some animal studies and some very early trials in humans, not necessarily showing that they prevent lung cancers, but showing that they prevent some of the changes that lead to lung cancer. And there are ongoing clinical trials in advanced lung cancer adding Celebrex to chemotherapy to see if that prevents progression. Well, we actually hear one of, and I'll be very brief about this, my research interest right now is something called Thunder of God vine, and this is a herb that is used in China in traditional Chinese medicine that has been used extensively in China in treatment of autoimmune diseases, in rheumatoid arthritis, psoriasis, and has been used effectively in that situation. And there are very small studies showing that it might have some effect in cancers, especially in cancer cells. And so we decided to use an extract of this in our mouse model in the lab, and we found some very, very exciting data that shows that this actually prevents lung cancer development in mice, especially in combination with aspirin. And so we're actively trying to develop this particular research interest, but it's something that we here at City of Hope are trying to think outside of the box and trying to develop this to impact lung cancer in a different way than the typical angles. So with that, I'm going to turn it over to Dr. Kim.
Thank you, Dr. Raz. So our second speaker this evening is Dr. Jae Kim. Dr. Kim joined the City of Hope's Department of Surgery in August 2011 and is the current Chief of Thoracic Surgery. Dr. Kim received his undergraduate degree from Harvard University and then graduated with his medical degree from the University of California at San Francisco. He completed his residency in general surgery at the University of California at San Francisco, as well as completing a research fellowship in thoracic oncology at the University of California at San Francisco Cancer Research Center, and a fellowship at MD Anderson Cancer Center in Houston, Texas. Please help me give a warm welcome to Dr. Jae Kim.
Well, thank you all for coming. So lung cancer at City of Hope is treated with a real multidisciplinary team approach. And the reason is because, well, the vast majority of patients that I see need treatment, not just by myself, but a whole cohort of, or a large team that typically involves medical oncology, radiation oncology, pulmonary medicine, palliative care, you name it, they're involved. But the main treatments that we have for lung cancer are surgery, radiation therapy, and chemotherapy. And some patients get one of these treatments. Some patients only get surgery. Some patients only get radiation. Some patients only get chemotherapy. Some patients get two of these treatments. And there are some patients who get all three. And which treatment the patient gets is dependent on the patient, meaning what therapies we think a patient will tolerate, and then also the tumor. And when I say the tumor, certain biological traits of the tumor will determine which treatments we recommend to the patient, but also, very importantly, the stage of the cancer. So this is a stark reminder of the progress that we really need to make in lung cancer. So if you see in red here is the 2006 survival rates, 5-year survival rates for different cancers, and in blue is the survival rates in 1975. And what you'll see is that overall, for all cancer, we've actually made quite a bit of progress. Prostate cancer, we've made a lot of progress. Breast cancer, we've made progress. Colon cancer, we've made progress. The cancer that kills more patients in the U.S. than any of these cancers combined is lung cancer. And it's really a tragedy how little progress we've made in improving the overall survival. And as Dr. Raz was alluding to, this is really because of the stage of the cancer. Most of the lung cancers are identified at this stage, which is advanced stage 4. And if you see, this is the percentage of the patients surviving. Hardly any of them survive 5 years. Whereas if you can catch the cancers earlier in stage 1, it's still not great. We can do a lot better. But you'd rather be on this curve than this curve. And today, about half the patients actually present with metastatic disease because we just aren't catching the cancers early. And it's only a small percentage of the patients that we can cure surgically and with surgery alone. Those are the patients who have local disease. And then there's this group of patients who have what we call regional disease. And that's where the cancer hasn't spread to distant sites, but it's gone beyond just the tumor, and it's spread to the lymph nodes in the chest. And so this is where we are today with all patients that we see. But if you look at patients whose cancers are identified by CT screening, about half of them, actually the majority of them, are found early and can be cured with surgery alone. And less than a quarter of them present with metastatic disease. And so that's why screening is really important. And despite all the great work we're doing in the lab and the cures that we're trying to identify, we know that we have curative treatments for lung cancer if we catch the cancers early. And those treatments exist today. So again, it's very important to figure out what stage of cancer the patients have, because it affects the it affects the treatment that we recommend, and it obviously affects the prognosis. So for patients who present with distant metastatic disease, a PET scan can show spread very far away from the tumor. And this is a patient who unfortunately presented with widespread metastatic disease. And then the question is, well, do they have local disease, which can be cured with surgery alone, or do they have regional disease, meaning do they have spread to the lymph nodes? Because we know that a lot of these patients do much better if they get chemotherapy before they get surgery. And some of those patients do better with chemotherapy and radiation and not surgery at all. So when we talk about local disease, patient has a tumor in the lung and it's just in that one spot, and basically surgery to remove the tumor can cure the patient. Regional disease means that the tumor is spread to lymph nodes in the chest, and a lot of these lymph nodes live along the windpipe here. And these are all the different stations or levels where the lymph nodes exist. And it's really important before we start giving treatment to figure out whether there's cancer in any of those lymph nodes. And as Dr. Raz mentioned, we have CT scans and PET scans, and they're pretty good for figuring out whether there's cancer in those lymph nodes, but they can be wrong up to 50% of the time. So on a case-by-case basis, we figure out if they need any other staging to figure out whether there is cancer in those lymph nodes. And the old-fashioned way we used to do this was something called a mediastinoscopy, where we'd make an incision in the neck and we would go down and biopsy some of these lymph nodes. Now, in the overwhelming majority of cases, we don't do that. And it's still appropriate for certain cases, but most of the time when we want to figure out whether there's cancer in one of those lymph nodes, we do something that's called an endobronchial ultrasound. And what that is it's a bronchoscopy, meaning this probe here is a flexible camera, and this camera is about the width of a pen. And we put it down the windpipe, and we have this ultrasound probe at the end of the bronchoscope. And the ultrasound probe is just like when women are pregnant, they get an ultrasound, and you can see through the wall of the belly, and you can see the baby. It's just like that, except it's much smaller. And with this probe, you can see through the wall of the windpipe, and you can see the lymph nodes. And then you can put a needle in and actually biopsy those lymph nodes. So here's a schematic showing the flexible camera, the bronchoscope. This is a lymph node that we're trying to get to, and this is a blood vessel right next to the lymph node. The ultrasound shows the lymph node and also shows the blood vessels to avoid. And you can actually see this needle going into the lymph node, avoiding the blood vessel. And we can get a very accurate biopsy that way. And it's actually just as accurate as the old-fashioned way, but with far fewer complications and without requiring an incision. So let's say we find that the cancer hasn't spread to any of those lymph nodes, and then we ultimately recommend surgery. What are the different options for surgery? Well, this is the standard traditional thoracotomy, which is a good way to treat lung cancer. It's tried and true, and for certain patients, there's no way to avoid doing this type of incision where we place retractors into the chest, and we actually have to spread the ribs apart so we can put our hands in and maybe feel the tumor, and some tumors, particularly tumors that are very centrally located, still require this type of incision. And across the country, over 75% of all lung cancer operations are done this way, with the spreading of the ribs. And but at City of Hope, we still do quite a bit of those operations, but actually the vast majority, over 85% of our lung cancer operations are done minimally invasively. And the minimally invasive surgery has been shown to cause less pain than the open operation. The improved lung function, especially right after surgery, faster recovery, and because the patients have less pain and can recover faster, they're actually able to tolerate any additional therapy, like chemotherapy, better than with a traditional open operation. And there's some evidence that there may actually be improved survival with this type of surgery compared with traditional open thoracotomy. And so this is the robot that we use to do our minimally invasive operation. It has 4 arms, one of which is holds the camera. And the camera is actually it's 3D and it's HD, so it gives us a really precise view of the lung and all the structures in the chest. And we can get a really close-up view of the heart and the lungs, and the beauty about the robot, as opposed to traditional thoracoscopic surgery, is that these instruments are designed to move the same way that your hands and fingers move. So it lets us do essentially almost the same operation as we do the open way, but with smaller incisions. So this is just a quick video of just a portion of a lobectomy, and this video is, the quality is not nearly as good as what we can actually see in the operating room. But I'll just show you. So these are robotic instruments. This is the lung. Here's the heart that's beating, and you can see while we're operating, we're always having to deal with the movements of the heart. And so this is a pulmonary vein that we're trying to dissect away from this vein. And because of the precise movements of the robot, and we've taken that instrument out and we're putting in a new instrument, we're able to do this really with a great deal of precision and really very safely. And so, we're dissecting out this vessel, separating it from this vessel. And what you'll see in a minute is we'll put a little piece of silastic tubing, or what we call a vessel loop, around it. And that helps us separate that vessel from the other vessel so that we can go ahead and divide it and tie it off. And when Dr. Raz and I do these operations, because one person is actually, the surgeon is sitting at a console which is about 10 feet away from the patient, we always do these operations with 2 attending surgeons. So when he's the surgeon, I'm next to the patient making sure that there aren't any problems with going on there, and vice versa. When I'm the surgeon, Dr. Raz is helping me, and he's standing right next to the patient. And with the robotic lobectomy, the scars are small, and again, we do 85% of our lung cancer operations this way. So, as opposed to the rest of the country, where it's the other way around, 75% are done open. So, if we are doing an operation here with a larger incision, with an open technique, it's almost always a complex operation. It's either a pneumonectomy or something called a sleeve resection, or we're having to remove more than just one lobe of the lung. And here's the difference. The old-fashioned way, the scar is about this long compared to the robotic technique, where you have more incisions, but they're all pretty small. Lastly, I wanted to talk about an exciting newer type of treatment that we offer for patients who can't undergo surgery, but we still think that they could be cured with treatment to the tumor alone, without any additional chemotherapy. So these are patients who still have perhaps smaller tumors, but just for whatever reason can't undergo surgery. So we have something called stereotactic body radiotherapy. And what it is it's focused high-dose radiation with pinpoint accuracy. And because of the ability to deliver these high doses of radiation while still sparing healthy tissue, it has rates of cure that are very, very high. And each treatment takes less than an hour, and most of the treatments can be completed within a week, instead of traditional radiation therapy, which for lung cancer, which typically takes about 6 weeks to complete. So this is a schematic or treatment plan, and what this shows is the way that we combine our advanced imaging, our CT scanning, so we get a good view of the tumor, and we use those images, and we use complex computer algorithms to help plan the radiation. And the radiation can be planned in such a way to deliver high-dose radiation, as you can see in the yellow here, just to the tumor, without radiating normal lung. And this is a similar picture. And you can see that this shows basically all the areas that are getting radiated. And in a traditional radiation therapy, you would see a more gradual drop-off. This shows the different colors show different amounts of radiation. And with traditional radiation therapy, you would see probably some blue all the way out to here, but we can actually really focus the radiation just on the tumor. So in summary, I think the most important take-home point is that we have treatments that currently that can really improve the survival and the cure rate for lung cancer, and could really decrease the number of patients dying from lung cancer. Those technologies exist today, but we just have to. It requires some political will, and it requires more people to be screened. Once patients are screened, it's important that we get accurate staging, and the staging is a combination of imaging, CT scans, PET scans, brain MRIs, and also for most of our patients, or for a lot of our patients, it also involves something called Endobronical Ultrasound. And then both for the staging techniques and for the surgeries, whenever possible, we offer less invasive treatments for better quality of life. Thank you.
Thank you again, Dr. Kim, so much for all that wonderful knowledge, and Dr. Raz. We are going to start the Q&A portion of the evening, and we already have a couple questions from our Facebook people. So I will go ahead and set these here and let you answer if you don't mind reading it out loud so that everybody knows. And each one of you can take it. And we'll keep them coming. So if anybody else has any questions, please give your cards over to Becky or to me and Marta.
Okay. I'll answer the first question from Suzanne on Facebook. How small do large tumors or masses have to get through chemo before you'll consider surgery? Well, that's a complicated question. There are a lot of patients who start out with large tumors, and as long as the tumors are not invading any critical structures, we'll offer surgery right away without any chemo. And then there are other patients who have large tumors who we know will eventually require chemotherapy. And so for a lot of those patients, we say, well, let's give the chemo first, because typically it's easier to tolerate the chemo before surgery than the other way around. And for some of those patients, even if the tumors don't shrink at all, we'll still go ahead and do surgery. And then there are some patients who have tumors that are really in important areas, or they have tumors that have spread to maybe one of the lymph nodes in the middle of the chest. And for those patients, we do like to see some kind of response before we'll do surgery, especially if someone's had a tumor spread to just one lymph node in the middle of the chest. We want to make sure that the tumor doesn't progress on chemotherapy. If we see that the tumor is spread to 2 or 3 lymph nodes after the chemotherapy, then what we know is that we can do really good surgery for those patients and actually take out all those lymph nodes. But most of those patients will actually have microscopic cancer cells that have spread past the lymph node. And doing surgery to remove the tumor is not going to make the patient live longer. It just means that during the time that they have left, they'll have to recover from surgery. So, so the size of the tumor is not as important as some of these other factors.
I'm going to take this one next. This was the first one from the audience. Should a person who has not smoked but had a lot of secondhand smoke be screened? That's an excellent question, and that's one that I think we hear a lot about. Currently, the recommendation is no. The difficulty is that we don't really have good data on patients who've had a lot of secondhand exposure. However, that is not to say that the answer will be no forever. So, for example, there are certain groups that have very high secondhand smoke exposure. For example, flight attendants who worked at the time when there was a lot of secondhand smoke on the airplanes. And there's part of the LCAP that I mentioned earlier is teamed up with a group of the flight attendants, and they're actually doing a study screening those people to help determine kind of the rates of lung cancer. The issue becomes that while secondhand smoke exposure is important, the overall rate of lung cancer is still relatively low, and there are obviously risks to lung cancer screening. One of the things that people are starting to think about is to order lung function studies on people who think they've had a lot of tobacco smoke exposure, and if those lung function studies suggest some emphysema, to then order CT scans, because the presence of emphysema in the lungs in a non-smoker puts you at very high risk for lung cancer. Did that answer the question, that part? Okay. You want to take it?
This next question is, can the Sbrt, that's the stereotactic radiotherapy, be done on lung cancer stage 4? Well, I think one way to look at stereotactic radiotherapy is sort of like it's radiosurgery. It delivers really high dose radiation to the tumor itself, and it's sort of like cutting out the tumor. It's not quite as good, but it's akin to that. So for a patient who has stage 4 lung cancer, meaning that the lung cancer has spread to distant sites, treating just the tumor, either with surgery or with high-dose radiation, again, will not do anything about those tumor cells that are far away. And even if we could eliminate all the tumor in that one spot, it's still not going to prolong life or increase survival. And then there are the side effects and the risks of the local treatment, which should be avoided.
All right. Next we have, I've been diagnosed having several lung nodules by a CT scan. 1.5 years later, with CT scans every 6 months, these nodules have not grown or increased. Would that indicate that the nodules are probably benign? So this brings up, the answer is, I would say yes, but obviously it's hard to say without reviewing all the medical information. But it brings up an important point, which is that many, many people have lung nodules. In the big NLST study, about a quarter of the patients who were screened had at least one lung nodule, but about 95% of those turned out to be benign. So the key thing is there are certain characteristics of how they look on the scan, and the other important thing is if they've grown over time. So in things that are not growing over time, typically tend not to be malignant, but sometimes once in a while we're fooled. So most of the times if things are not growing, they tend to be benign. I'm just going to take this follow-up one real quick because I think this is important. If I wanted screening at City of Hope, how would I do that? So you call the new patient services number, which I'm embarrassed I don't remember, but Anna Kathy probably knows. Do you know the new patient services number? Did everyone get that? We have outside, we have some information also. Yeah, and we have brochures in the front also, but they know exactly what to do when you say, I'm interested in lung cancer screening. They go through your information, they ask you some brief questions about your age, how much you've smoked, and then take all your information, and then one of our, someone from our team contacts you to explain the issues regarding the kind of flow of how everything goes. You then get set up for a CT scan. You get your CT scan. If after your CT scan you get a phone call with the results, and essentially the results are either there's something that requires another scan to follow up on, some nodules, or we'll see you back in 12 months' time. Oh, okay. For new patient services. Okay. All right.
Okay, I'm gonna answer these two questions together. So Heidi asked, "Can you tell me how you would get involved in a clinical trial?" And then someone else asked, "What clinical trials or new treatments are available?" So the answer to both of these questions you can find at our website, and if you do a Google search for clinical trials City of Hope, it'll take you to the clinical trials online website of our web page, and it'll show you not just the clinical trials for lung cancer, but all the clinical trials and at City of Hope. And then there's a part two to this question: stem cell treatment progress. There aren't any stem cell treatments available for lung cancer, but that is an area of research. Actually, when Dr. Raz and I were in the lab, we together at UCSF, we were actually looking at stem cell pathways involved in lung cancer, and that's still something that is an exciting area of research, but there aren't any current treatments available.
All right, this next one is from Evelyn on Facebook. What are the treatment options for advanced non-small cell lung cancer patients with mutated EGFR? Also, are there any hospitals in the U.S. that have started using afatinib? Well, as I mentioned, currently for advanced non-small cell lung cancer, the only treatment approved is erlotinib. There are other treatments that are potentially effective for EGFR mutated lung cancer, but those are mainly in clinical trials. Oftentimes there are small molecules or antibodies that target that same receptor in combination with other receptors, but they're mainly in people who've progressed with Tarceva, and again, mainly for people with advanced lung cancer. But again, there are ongoing trials at City of Hope and elsewhere, and you can either go to the City of Hope website, search for clinical trials, or go to clinicaltrials.gov to find clinical trials elsewhere.
So this next question, can you briefly describe some of the symptoms of stage 1 lung cancer and also symptoms of stage 2. Well, that brings up a good point, is the reason that most lung cancers are found at stage 4 is because most patients actually don't have any symptoms until stage 4. So it's not like colon cancer where there might be blood in the stool, or breast cancer where you could feel a lump. In the vast majority of cases, there aren't any symptoms until the cancer has spread well beyond where it's curable. The most common symptoms, the most common symptom of either stage 1 or stage 2 lung cancer, if the patient does have a symptom, is actually cough. But the vast majority of patients who have a cough don't actually have lung cancer. So, but cough would be the most common symptom, and certainly it's anyone who has a significant history of smoking who has cough accompanied by coughing up any blood or blood-tinged sputum. That is a concerning symptom.
Okay. Any increase in number of lung cancers in younger age groups with the popularity of hookah bars? That is a very good question. It's interesting. We, as part of our tobacco exposure program that we have here, we're collaborating with Claremont School of Public Health, and they're actually looking into hookah exposure because it's actually not studied very well, and it's also not regulated by the FDA, the tobacco that's sold by hookah. And in fact, many people don't consider the tobacco from hookahs to be detrimental to health. So there's very little that's known about that, even though it's used pretty widespread in the Middle East and Mediterranean countries. But I thought that was a very, very good question.
This next question is, any advice on nutrition or diet, and any supplements to recommend? There have been a lot of studies looking at different environmental or nutritional supplements that could potentially prevent not just lung cancer, but other forms of cancer. And I think that no one vitamin or supplement has been shown to be preventative for lung cancer. The advice that I give to my patients is, eat a balanced diet, lots of fruits and vegetables, and I think the most important thing is sort of to avoid processed foods as much as possible. And so I tell patients to eat food that's food. Eat food that your grandparents would recognize as food. If you were to give a Twinkie to your grandfather, I don't know if they would look at that and say, well, that looks like food. So I think the most important thing is to avoid processed foods as much as possible, eat lots of fruits and vegetables.
All right. With a patient with stage 4 lung cancer in both lungs, what options are available after chemotherapy has been unsuccessful? Well, most people consider stage 4 lung cancer to be not curable, and so the goal of treatment for stage 4 lung cancer is really to palliate symptoms, to make symptoms better, and if possible, to prolong life if that can be done in a way that achieves good quality of life. And typically when chemotherapy has been unsuccessful, there can be measures to help with comfort, but that's typically what's available. There have been rare cases with a very rare type of lung cancer where lung transplants have been used for what used to be called bronchoalveolar carcinoma that was limited to the lungs. But that was tried in a very, very limited group of institutions and had very, very limited success. I would say that's a very extreme situation, and for the most part, the treatment focuses on symptoms and making sure that best possible quality of life is achieved.
So this question, I was told by a surgeon that all you need to do with a lung tumor is go in and put a barrier around it to keep it from spreading. Will that really keep you from dying of lung cancer? Well, that's not a treatment that I am aware of. Typically, we remove the tumor, and there is no barrier that I'm aware of that will keep cancer cells from spreading. There are some studies going on right now looking at if we can remove less than an entire lobe of lung. So typically the treatment for lung cancer, for surgical treatment, is to remove one lobe of the lung. And we have 3 lobes. We have three lobes on the right side and 2 lobes on the left side. So there's a study going on right now looking at if we remove less than a lobe, like we do for breast cancer, instead of doing a mastectomy, do a lumpectomy. So kind of do a lumpectomy for the lung. If we put in some radioactive material, will that help keep the lung cancer from coming back? And I guess that radioactive material could be thought of as a sort of barrier, but I don't know of any barriers to keep a tumor from spreading.
Next question is there any clinical research for non-smoking Asian women men has predisposition of genetic defect on lung cancer? Well, I think just about a week or 2 ago there was a publication on never smoking Asians and lung cancer, showing a new genetic area that may be a little bit different than other people for predisposition for lung cancer. I don't know that we know what to do with that information yet, but and it certainly was not the kind of effect where if you have that genetic change, it means you're going to get lung cancer. It means you're at a slightly higher risk. But I think it's a very interesting observation that there is something different about the biology of the cancers that women, and particularly, especially in Asian women, get, and it's really fascinating, and a lot of people are working on it, and so far we haven't really been able to come up with answers on why it is that this group of people get different types of cancers.
Are other types of tumors treated the same way as lung tumors? Example, bladder tumors that have settled in the lung. So I think this question is asking whether, the majority of tumors in the lung are actually cancers that have spread from other places and gone to the lung, not primary lung cancers. And what we've been talking about mostly this evening is primary lung cancers, cancers that start in the lung. But a lot of different cancers actually end up spreading to the lung. And bladder cancer is one of them. And for a lot of these tumors, we can actually do surgery to remove those tumors. But it's in a very select group of patients who have just a limited amount of disease where we feel like if we did surgery, we could remove all the tumor that they have, and it's for patients who we feel like would really tolerate the operation. But the majority of patients who have cancer that's spread to the lung from other places, though, are not helped by surgery and are treated mostly with chemotherapy.
Okay, this next one is, can you comment on the use of natural adjuvant therapies such as IV vitamin C, Escazine, IV hydrogen peroxide, insulin potentiation therapy, and are they being used at City of Hope? No, not to my knowledge. There are a lot of things that fall in the realm of alternative and complementary therapies that have not some of which have been investigated, some of which have not been thoroughly investigated. The best I can say is, if it makes you feel better, that's great, but you probably don't spend a whole lot of money on it because a lot of them are not effective. But that is not one of the alternative and complementary therapies that we're evaluating here at City of Hope.
So this next question asks about how to detect radon in your living environment. And that's an important question because, as Dr. Braz mentioned, radon is a risk factor for developing lung cancer. Well, actually, there are kits that you can get that will detect the amount of radon in your home. When you actually have to do the tests very carefully because you can cause false elevations in the amount of radon that's detected. For example, there's a natural amount of radon that's emitted by stone and by granite, for example. So a lot of people are worried about, unnecessarily worried about granite countertops and the radon being emitted from granite countertops. And you take one of these granite radon detectors and put it on your granite countertop, and then if you cover it with something, then it'll register a really high radon level. But it's actually not an amount that is considered to be dangerous. There are kits that you can buy, but just and especially kind of older homes, it's important, and particularly like if a lot of homes have like California basements, that's a good area to check for radon emissions.
I think we talked about this question. I'm not sure. I think you're talking about metastatic.
Yeah, I just answered.
Okay, all right. So that's it.
Yeah, I think
that's all the questions. Are there more?
Oh.
Okay, so this comes from YouTube. How new is Sbrt, and is it available anywhere else in the U.S. or internationally? What is the success rate with Sbrt versus traditional radiotherapy? Well, it's older than YouTube, I think, and it is available at many, many other places. Sbrt just means high-dose focused radiation that's given in a small number of fractions. It goes by other names like cyberknife, and those are just different names of equipment that are used to deliver the high-dose radiation therapy. And the success rate largely has to do with the size of the tumor and also the location of the tumor. But for tumors that are small, meaning tumors that are 2 centimeters or even 3 centimeters and smaller, the chance of recurrence within the lung tissue itself is small, probably somewhere in the 10 to 15% range. Doesn't mean it can't recur elsewhere in the body, but within that particular area, it's probably around in the 10% range for very small tumors. And in traditional radiotherapy, which is still used for bigger tumors, that rate is higher. We still use traditional radiotherapy for larger tumors or tumors that are closer to critical structures that, for whatever reason, can't receive the stereotactic radiation therapy. But this is not something specific to City of Hope, but I think one of the unique things about coming to an institution like this is that we have a multidisciplinary team that can evaluate patients with lung cancer and determine what is the best fit for a particular patient. Is it surgery? Is it stereotactic radiation therapy? Or what have you. The thing you don't want to do is say, well, you're too old or too sick to have anything done, because that's usually not the answer. There are very limited situations for patients with stage 1 lung cancer where you can't get some kind of treatment. And we do know that without any treatment at all, that lung cancer is almost always fatal within a couple of years. So, good question. Any other questions, or do you have another question? Looks like we have one more question. Dr. Kim's turn.
Thank you. If one's insurance company or healthcare plan does not offer a type of lung cancer treatment available at City of Hope, are they required to allow the patient to receive it at City of Hope? Yeah, that's a good question, and I think it does depend on whether if it's a treatment that we offer here that we can show is clearly better than the treatment that the insurance plan is recommending, then most insurance plans will allow some kind of exception. But if it's an experimental treatment or even a trial, then the insurance company typically will not pay for it.
Thank you all for coming.
Thank you.
Thank you. Oh, and just as a friendly reminder, please fill out your evaluations, which are the blue sheets. Again, we really appreciate your comments. And we will be collecting those on the way out. Thank you. Thanks, guys.